So structure of the presentation, as I've said, what is RRR, why would you carry one out, what the early implementers did and what they discovered, and then some steps about what you need to think about if you were to carry out your own RRR audit. What is RRR? Initiative, I guess, from within NHS England, and there has been an RRR clinical program set up within NHS England a number of years ago, and our work was part of the work that they were doing as a program. They approached us and asked us particularly whether we would like to engage with their program, and we thought it was a good opportunity to do some national work as well as help support the work that we were doing locally with the Year of Care tariff. So what is RRR? The idea is that a patient's pathway within acute hospital can include a number of different phases. So the first phase might be considered the pre-admission community phase. So this is your outpatient appointment. It might be step-up services. It could be GP services referring you into acute hospital. So before you get to the acute hospital itself. And then within hospital, there's normally an acute phase where you receive services of an acute nature. And then generally, there is a recovery, rehabilitation and reablement phase that occurs after that. So that could be a step-down care. It could be carried out within the acute hospital itself. It might be, a patient might be transferred back to a nursing home and receive some of that recovery support in that home. So it's a phase which could be within the hospital, or it could be outside of it, and often is going to be both of those to some extent. The idea of RR, as I said, the acute phase is going to have some assessment phase within it, which will talk about what your recovery, rehabilitation and reablement needs are. And these are some of the things that we try to understand during the clinical audit, or the early implementers try to understand. So they talked about an R point, and we'll come on to what that means in the next slide. The main role of the national program in RR was what they asked us to do was to look at whether it would be possible to identify an amount of support that was carried out in an acute hospital, amount of support for recovery, rehabilitation and reablement that occurred in an acute hospital at the moment, which could be transferred to another setting, whether that be a community hospital or a nursing home or whatever. Their national understanding, or what they were looking at nationally, was whether there could be whether that service, that RRR service that is currently occurring in acute hospital, could be identified and unbundled from the acute activity tariff, and the money transferred to the new service delivery provider, whether that's the community hospital or the nursing home, rather than being paid to the acute hospital. So it's looking at the acute tariff and saying a portion of this will be for the acute care, but a portion of it might be for RRR, and we could take that money and give it to another setting and provide better service to the patients in that new setting. So the RRR was talking about whether there was a portion of the HRG and the acute tariff for that HRG which could be taken out and transferred somewhere else. The key points in terms of the clinical audit was to identify when the RRR phase started. So one of the key learnings from the early implementers was to undertake some understanding of the different points of the patient stay within acute hospital. So as I said, there's an acute phase and there's an RRR phase. And the program came up with two particular key points in that pathway, one called the R point and one called the L point. So the R point is the point at which the patient's RRR needs can be accurately assessed. And the L point is the actual date where a patient is medically fit for discharged. It was termed the L point because of it's sometimes referred to as a liberation point. So the idea is that at some point in the patient's pathway, you should be able to make an assessment, an accurate assessment of what their RR needs will be, and then sometime after that point, the patient will actually be medically fit for discharge. And it's what the early implementers decided within the RR audit was that the L point is the key one, because if you are looking at unbundling the unbundling part of the acute tariff, or you're talking about shifting a patient from acute service to another service, then it's the L point which is the key one, the key point for this program. So we need to keep that L point in mind. So it's the point when a patient is medically fit for discharge. The audit that was carried out by the early implementer teams was specifically around for chronic conditions. So they were looking at patients who had long-term conditions, as fits in with the LTC program that we are running. It was based on some work on a similar audit that was carried out for hip fracture. So there was some previous work carried out where patients who were admitted with hip fracture received procedures, and then the clinical audit, RR audit, was carried out on those patients to understand when they could be discharged from acute hospital into another setting. And the idea about moving it to chronic conditions was for a number of reasons. We wanted to understand whether the RRR concept, which works quite well for hip fracture and when you've got surgical procedures, it works quite well for surgical procedures. But would it work for chronic conditions? Because the care of patients for chronic conditions are quite different from a surgical procedure in terms of understanding, having a consistent RRR need at a particular point. The reasons why the early implementers were keen on carrying out this audit, I think this is the crux of what we're talking about. So nationally, as I said, their main point of view was looking at the acute tariff and whether you could unbundle some of that acute tariff for RRR services. Locally, they were looking at it in a slightly different way. They were more particularly interested in how the audit might support discharge planning. They're also interested in the unbundling the tariff, but as we see it, we don't think they didn't conclude that that would be a major part of the way they want to move forward, but they found the audit particularly useful for understanding their discharge planning process. The other aspect that they found particularly interesting and useful was that it was something that their providers were interested in. So it was a way of engaging with their community and acute providers, because everyone was keen on providing a better service to patients by discharging those patients from acute care at an earlier stage, if that were possible and safe, of course. So it was a good way of engaging with other providers. The process of an RR audit is relatively simple. You need to identify a group of patients who it might be suitable for, and then you need to carry out those clinical audits. And the way that we were recommending to them was that they would carry out a daily audit for each patient to assess basically three things. And those three things were: what is the L point? So what is the end of the acute phase and the beginning of the RR phase? So in our previous slide, that we've called that the L point. So how do you assess, can you assess that accurately at a particular time for each patient? The second point was to understand the level of RRR need for each patient. So make an assessment of whether that patient is likely to have high needs or low RRR needs when they were medically fit for discharge. There was a lot of discussion about what was high and what was low, and that was one of the major discussion points and things that each came up with their own local definition about the level of need. And finally, what they were looking at is the reason for the RRR phase. So why was a patient staying in acute hospital for that RRR period? Was it that the service was only provided in an acute hospital, or was it for some other reason? And we'll look at some of those reasons a bit later on. So I'm diving in now to some of the results of the RRR audits that the early implemented teams carried out, just to show some of the outcomes from this work. So I've chosen in this slide to look at two of our early implemented teams. One is Stoke and North Staffordshire, and one is Leeds. And what we're showing here are the average number of days, so the length of stay, and also the length of days beyond the R point. That should read L point. But the length of the RRR phase is in red there, and the length of stay for patients is in blue in these graphs. And we're looking at a range of different conditions, chronic conditions. So I want to say at this stage that the early implementers were asked to look at 4 long-term conditions or chronic conditions in particular, and they were COPD, diabetes, heart failure, and stroke. Some of the early implementers decided they wanted to extend that, so Stoke and North Staffordshire added UTI and syncope and collapse as 2 other chronic conditions that they were particularly interested in. Leeds took a slightly different approach, and they chose all patients who were admitted to an elderly ward. So they looked at the data by condition, but they actually looked at a much wider range of conditions, but for a particular group of patients. I think from this data, what we can conclude, or what the early implementers were able to conclude, was that, well, the first thing to note, I guess, is that the Stoke and North Staffordshire, the length of the RRR phase appeared to be much shorter than at Leeds. So to explain this, they came to the conclusion that either at Stoke and North Staffordshire there was some of the RRR service was already delivered outside of acute hospital. So one of the things they were looking at is whether in Stoke and North Staffordshire compared to Leeds, whether they were regularly discharging patients to community care or to services outside of acute hospital at an earlier stage already. And so perhaps Leeds had a bit further to go in terms of developing their community services. There was some complications in that the Stoke and North Staffordshire patients were generally younger, and the Leeds patients, because they took all patients admitted to an elderly ward, were all older people. The other consideration was that, as we saw, there's an R point and an L point, and Leeds, after some consideration, decided that they were actually using the R point rather than the L point. So they were looking at the point at which you could make an assessment that RR was what level of RR and what services were required for RR was, rather than the point at which the patient could be discharged. There is a clear relationship between the age of patients and the length of the RR phase. So all of our early implementers had information like this, which showed that for older patients, generally the RR phase was longer than for younger patients. So these data show three particular things. There's a strong relationship between age and the length of stay. There's a strong relationship between age and the length of the RRR phase. And there's a strong relationship between age and the proportion of the length of the stay which is in the RRR phase. So what we're saying there is, if we look at the Leeds patient over 65, the length of the RRR phase is about 50% of the total length of stay, whereas if we look at those patients under 65, only 16% of that length of stay is considered to be RRR, for RRR within the acute hospital. So there's a strong relationship with age. What I'm trying to show here, we've got 4 different early implementer teams here. BHR is North East London, we have Kent, we've got the Stoke, North Staffordshire and Leeds early implementer teams. And just looking at the 4 conditions that we asked them to look at for this particular study. And all we're looking at is the length of stay and the length of the RRR phase in these 2 graphs. I think the thing that strikes you from this graph is that there's quite a bit of difference between the different early implement sites and between the conditions in both the length of stay and the length of the RRR phase. And I think this comes to one of the major conclusions from the early implementer study, in that they found it difficult to ensure consistency in the length of stay. There was quite wide distributions of the average length of stay and the average length of the RR phase for these chronic conditions. And I think their conclusion was that for chronic conditions, it would be difficult to identify a particular point which is consistent for all patients at which the RR phase starts. So unlike a lot of the surgical conditions, identifying a particular phase for a group of patients would be difficult. This, I think, is one of the more interesting findings from the audits that were carried out. So the top graph is looking at the percentage of all patients within the audit who either had no RRR needs or what was the reasons for their RRR. So if we look at the pie chart, you can see that about 3/4 of the patients, the clinical audit found that patients had no RRR need. They were discharged, or no RRR phase spent in acute hospital. So they were discharged without requiring any RRR, or they received all of their RRR services outside of acute hospital. And then if we look within the remaining 1/4 of patients, about 1/3 of those, the reason for the RRR phase was medical conditions. A bit over 1/3 was awaiting assessment, and a number of patients were awaiting a bed. So when we're talking about awaiting assessment, what we're talking about is a community or social care reason for delay. So this is awaiting assessment or awaiting for a bed. So either the acute or the discharge team from the acute hospital, often that's a multidisciplinary team, was identifying that the patients had a need for RRR, but they felt that that patient should be suitable for a care package which would support them once they left hospital. And so the reason for remaining in acute hospital was the time required to set up an assessment of those patients. Or some patients already had a care package, but there was not a social care or a bed in a nursing home that was suitable for them at that time. So the main reason for the patient staying in acute hospital was that they were waiting for a bed to become available that they could move to. There were a small number of patients who had patient reasons for not being discharged. These were that they didn't have a carer at home, or they didn't feel that they were ready to go home yet. So there were a number of reasons why patients felt that they weren't they shouldn't be discharged at this point. But I think the key thing here is that there were medical reasons why the patient couldn't be discharged, and there was a discussion about if there's medical reasons, is it truly part of the RRR phase? But there was a big discussion about that within the early implement sites. But I think to see that over half of patients were receiving an RRR phase because they were waiting for assessment or awaiting a bed was a big wake-up call to a number of the early implementers, because I think that showed the providers and the CCG that actually the discharge planning process wasn't as efficient as it could have been, and that there were areas to work on. And just looking at those reasons again, so these are only looking at those patients who spent some of their RRR phase within the acute hospital, and looking at the discharge destination of patients at Stoke and North Staffordshire and at Leeds. Most of those patients who had an RRR phase were being discharged. If we look at the Stoke and North Staffordshire to start off with, the bulk of patients who had spent an RRR phase within the acute hospital were patients who were going to be discharged to another hospital or to residential care. So their nursing homes were efficient. The patients were discharged to a nursing home at an early stage because they were getting the support they needed in that nursing home, but some of the other residential homes and other hospitals, there was a wait for discharge. In Leeds, it was quite a bit different, but in some respects, it's quite similar. So the RRR phase for patients who were discharged home was reasonably small, but those going to residential care, to respite care, to an intermediary care bed, spent longer RRR phases within acute care. So to go back to the original purpose for the RRR audit, the reason that our early implementers carried out this RRR audit was partly a proof of concept for the national program. Could the audit methodology be applied to chronic conditions? Could the method be consistently applied between various hospitals? And could the PBR tariff be split such that an unbundled RRR portion of that tariff could be spent within a different care setting? The conclusions at a national level that the early implementers came to was the methods could be applied to chronic conditions, but it was very difficult to pin down a particular, it was very difficult to ensure consistency. So the specificity of method, of descriptions of the L point and the R point, and what was high and low RRR need, and the ability to apply those definitions consistently, and the variation in the services that patients needed when they had a chronic condition, made it very difficult to identify a particular length of time for the RRR phase in a particular hospital. And so actually unbundling the RRR phase from the acute tariff is unlikely for chronic conditions, or difficult. However, they found that the audit methodology was very useful in terms of understanding their discharge planning process and looking at ways of improving that. What I want to show you now is just talk to you briefly about is to look at how you might carry out your own RRR audit and what are the steps that are involved. And the reason I'm going to present this to you is that the early implementers wrote a paper that describes this step-by-step methodology. And so this is kind of an introduction to that paper. So in terms of selecting patients, these are the three key things that the early implementers came up with. Was that it needs to be kept simple So, for example, as I mentioned, one of our early implementer sites selected all elderly patients admitted to a particular ward, and that made it very easy to actually identify the group of patients you were going to audit. They felt that there was some benefit in setting a lower time limit. So if patients are only remaining in hospital for 2 or 3 days, then they're unlikely to be spending much RRR phase within the acute hospital. So they felt that it would be appropriate to set a lower time limit and only audit patients who remained in hospital for perhaps 5 or more days. And they also felt that selecting patients, you wanted to select a time period for the audit. Okay, so for example, if you were looking at all patients admitted to an elderly ward, you'd want to look at all patients who were admitted to that ward for a month, just to make sure that you've got a clear cut-off for the patients who are being included in the audit. So rather than pick particular patients on that ward, pick all the patients, and rather than pick them for an arbitrary length of time, set a time limit, perhaps a month, and audit all patients who are admitted for that period of time. In terms of the data collection itself, there was variation in the way that the early implementer sites carried out their audits, and it was mainly in this, whether it was a prospective or a retrospective audit. So what we mean by this, a prospective audit would be to carry out the audit as part of the daily ward rounds, for example. A retrospective audit would be to collect audit information from the discharge notes at some future date. So are you looking to identify the R point at the time, in real time, as the patient is moving through the pathway, or would you be just auditing a month later once all the discharge notes are finalised and the patient has been discharged? Effectively, what the recommendation for the early implementers is that it should be a prospective audit, because the whole point of this audit is that it should link in with your discharge planning process, which should be happening in real time anyway. And so by using the audit alongside of your discharge planning process, it makes sense to do the two together as a prospective audit. You need to choose an efficient way of doing it, either someone collecting the information during the daily ward rounds, or one of the sites had a clinical nurse who was part of that ward round just filling out the audit once the ward round had finished rather than during it. And as I said, it needs to fit with the current discharge planning process, so choose a method which fits in with that. In terms of the data items that should be collected, the paper that I'll describe in a minute, that I'll show you the link to in a minute, has a list of data items that the early implementers felt were essential, and then a whole load of others which some of them felt were useful and others didn't. So there's a range of data items that you could use as part of your items. In general, we would recommend a smaller list just to make the audit easier, particularly if it's going to be collected during ward rounds. So you'd only want those items that illustrate the purpose for doing the audit in the first place. So if you're using the audit to understand your discharge planning process, you should limit the audit to those data items which illustrate factors about your discharge planning process. And also only collect those that are going to be easy to collect. If it's too difficult to collect, then you need to weigh up the benefit of collecting that data item against the resource that's required to collect it. In terms of the analysis, again, it's got to be relevant to your purpose. So really what we're talking about is gathering evidence to support service change, in terms of your discharge planning process, or possibly for inclusion in contracts. Or the other one that the early implementers went on to use the information for was to put into a simulation model. So Bev mentioned right at the beginning that as part of the RR audits for the early implementer sites, the program commissioned an organisation to develop a simulation model for RR. So the idea here is that the data you collect during the audit could be put into a simulation model, and the model would give you some understanding of the variability and the cost of shifting services out of acute into a community hospital. So that model is available on our website, and I'll give you the link for that in a minute. So it's an additional way of gathering evidence to support your service change or support inclusion in contracts and different things like that. So just to finish off, this is what I've been talking about. There are two documents and the simulation model, all available on the Long-Term Conditions Year of Care commissioning model website. So the website address is there. The audit report talks about the results from the audits from the early implementer sites. The step-by-step guide takes you through how you carry out your own audit, and also takes you through how you would use the simulation model. And then the simulation model is available for all of you to use once you've collected your data on the website as well.